Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare and life sciences. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the lawyers at Epstein Becker Green, a leading law firm that has decades of experience serving clients in the healthcare and life sciences industries nationwide.
Today on Diagnosing Healthcare, we will discuss recent updates on implementation of the drug pricing provisions of Inflation Reduction Act and the industry's response. Hello and welcome. I'm your host, Alexis Boaz. I'm an attorney in Epstein Becker Green's healthcare and life sciences practice based out of our Washington, D.C. office. At the end of June and in early July, the Centers for Medicare Medicaid Services, or CMS, made significant headway in its implementation of the drug pricing provisions of the Inflation Reduction Act, including the release of the revised Medicare Drug Price Negotiation Program guidance. With CMS's September 1st, 2023 deadline to issue its list of drugs up for the first round of negotiations, and with the unique process CMS has used to implement the IRA, industry and other stakeholders have been struggling to keep up with, respond to, implement, and comply with all the new provisions under the IRA over the past few months. On today's show, we're going to talk about these recent updates and the industry's perspective of the quickly moving implementation of the IRA. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. Joining our discussion today is Sylvia Yu. Sylvia is the Vice President and Senior Counsel of Federal Programs at PhRMA and oversees PhRMA's legal advocacy on federal drug reimbursement, pricing, and coverage. Before coming to PhRMA, Sylvia worked at HHS's Office of General Counsel in the CMS division. Thank you for joining us, Sylvia.
Thanks, Alexis. I'm glad to be here.
Also joining us today is Connie Wilkinson, a member of the firm here at EBG. Connie concentrates her practice on pricing and reimbursement policy, commercial pricing, federal healthcare and health benefits program issues, and contracting strategies for the pharmaceutical, medical devices and products, and biotechnology industries. Connie regularly advises direct and indirect providers in the healthcare industry regarding pharmaceutical pricing and program compliance. Thank you, Connie, for joining us as well.
Good morning, and thanks to all of our listeners for participating.
Let's dive into our discussion. In our last Diagnosing Healthcare episode on the IRA, we discussed that the IRA included substantial changes to drug pricing under the Medicare program. Some of the most high-profile changes include the creation of the Medicare Prescription Drug Inflation Rebate Program that imposes a penalty for drugs with price increases that are faster than the rate of inflation, changes that increase the financial liability of manufacturers in Part D prescription drug plans by redesigning the Part D drug benefit, and the creation of the Medicare Drug Price Negotiation Program. At a high level, under the negotiations program, CMS will select drugs it determines to be high expenditure drugs and will undergo a negotiation process with the drug manufacturer to reach the maximum fair price, or MFP, for the drug. The MFP must ultimately be no more than the price ceiling that CMS will also calculate. The MFP will go into effect for the first 10 Part D drugs selected for the negotiations program in 2026, the first applicable year for the program. Congress allowed CMS to implement most of the IRA provisions through guidance documents rather than through the typical notice and comment procedures. Even though CMS issued their expected timeline for some of the more high-profile updates, stakeholders have been subject to a whirlwind of guidance documents, notices, letters, and other information from CMS's website, the Health Plan Management System website, announcements and letters issued at various intervals over the past few months. In addition to navigating through keeping up with all the updates, stakeholders have been under extremely tight timeframes to submit feedback with a lack of certainty of how CMS intends to consider and incorporate feedback. Sylvia, what has been the biggest challenge for industry over the past few months as CMS has implemented the IRA?
Alexis, this is a very new and, in CMS's own words, novel and complex law. This new law is already having a lot of impact on how pharmaceutical companies are thinking about research and development and their long-term planning. Companies have to worry about what their future trajectory is in a way that we've not seen before. We're going to talk more about how the IRA does this, but in short, by imposing below market price caps on existing drugs, the IRA weakens the incentive to develop new medicines. Even CBO has identified this in an April 2021 report on pharmaceutical R&D. They pointed out that the result of this will be fewer drugs because there will be less incentive for companies to spend on research and development. In late 2022, PhRMA conducted a survey of its members, asking some questions about how the IRA price-setting provisions are already impacting companies and how they would be planning to move forward with R&D plans. And based on this survey, we found that 3/4 of the members that were surveyed said the law creates significant uncertainty for research and development planning. 95% of our companies said that they expect to develop fewer uses for medicines because of the limited time available before being subject to government price setting. And 82% of the companies with pipeline projects in cardiovascular, mental health, neurology, infectious disease, cancers, and rare diseases all reported substantial impacts on R&D decisions in these areas. Look forward to talking in more depth about some of the problems that we have already seen with the law and the CMS implementation.
And Connie, what are some challenges that you've seen with CMS's implementation of the IRA over the past few months?
I think there are a couple of broad buckets of issues with the way we've seen this roll out so far. The pace of implementation is certainly an issue. The breadth of what CMS is trying to accomplish in such a short time period has also been staggering for people when you talk about the proliferation of the different guidances, quick turnaround, short time periods for response. And the third would be really overreach in some places in terms of the approaches or interpretations that CMS is trying to advance that go far beyond a reasonable interpretation of this statute. And I know in certain circumstances, there are arguments that what they're doing is not even consistent with the law. We'll talk a little bit more about the litigation in a minute. But I think that when you look at what the IRA actually does, it doesn't do just one thing. We talk about it as trying to reduce drug prices, but it's doing this through several different vehicles and several different programs. The negotiation element itself, if we're willing to call it negotiation for the moment, that program is completely new. They've never negotiated prices under Medicare before. In addition to that, we have the transition from the old to the new rebate program. And then at the same time, you have the elements that are redesigning the Medicare Part D benefit. So there's lots of moving parts, maybe too many at once, taking place in a very limited period of time. And because of that, it's not just reading the latest thing that CMS has issued under this program. It's trying to keep track of all the moving parts across all the elements that will be impacted by the IRA.
I was just going to give you a shout out to say it sounds like clients will need good federal drug pricing lawyers like yourself, Connie.
And I will tell you that I'm sure many of my colleagues also are poised and ready to assist, but thank you for that.
As CMS's implementation of the IRA has progressed, some stakeholders have made their positions known through the lawsuits they've filed, including one from PhRMA. Sylvia, did you have any comments?
Sure, Alexis. PhRMA filed a complaint last month in the Western District of Texas. We are joined by two co-plaintiffs, the National Infusion Center Association and the Global Colon Cancer Association, which represent both provider and patient interests. We are raising constitutional claims against CMS. Many of these claims are claims that we will also see or have seen in individual member lawsuits.
Connie, could you provide an update on the current landscape of litigation?
If we look over the last couple of months, we've seen 6 different lawsuits filed, including the PhRMA litigation, and they're distributed, interestingly, across the country. We've got the litigation in Ohio filed by the U.S. Chamber of Commerce, and most recently, they also filed a motion for preliminary injunction in that case. In addition, in New Jersey, Bristol Myers Squibb filed litigation. And just last week, Johnson & Johnson, through its Janssen subsidiary, filed also in New Jersey. And then Astellas has filed a lawsuit in the Northern District of Illinois. And I believe they were the most recent one filed. In many of these lawsuits, there is some overlap in the allegations that are being made, as Sylvia alluded to, both Merck and BMS, and in the new J&J litigation, allege that the IRA violates the First Amendment because it compels speech, and the Fifth Amendment because it represents an uncompensated taking. The PhRMA's lawsuit has an allegation about excessive fines based on the excise tax penalty and a separation of powers argument, which we do see in some of the others. And in the J&J suit, there's also an allegation that the negotiation program creates an unconstitutional condition on Medicare and Medicaid participation that otherwise is not present in those programs, and that this is exhibited by the fact that the manufacturers have to surrender core property rights in their products in order to participate. J&J also, or I should say Janssen more accurately, also raises the question of the nomenclature under the IRA and whether the negotiation reference is a misnomer or whether it's really a deception, and emphasizes the fact that, in their view, that there's no offer, no negotiation, and no fair price that results from this program because of the coercive effect of the way it's being imposed on manufacturers.
I'm sure industry is still processing the revised guidance and preparing for the September 1st due date for CMS to release its list of 10 drugs that will be subject to negotiations. Sylvia, are there any particular aspects about the negotiations program you want stakeholders to better understand?
Yes, Alexis, and I think Connie has already previewed what we see as the biggest concern with the IRA, and that is that it really is not a true negotiation. And you will hear me and others refer to it as, quote, price setting, which is how the pharmaceutical industry views this new program. Anyone who's read the statute and understands how this process will work, you'll quickly understand that this is not anything close to what is commonly understood to be a negotiation. First off, the statute was written in such a way that the manufacturer is forced to accept the price that's offered by CMS, the MFP, the maximum fair price, as Congress labeled it. If a manufacturer does not agree with CMS's maximum fair price, it can only do two things. It can either, one, be subject to a very steep daily excise tax on all of the drug sales that effectively puts the manufacturer out of business, or the manufacturer can choose to terminate its Medicare Part D agreement and its Medicaid drug rebate agreement, which essentially means withdrawing all of the manufacturer's drugs, not just the drugs subject to the MFP, from Medicare and Medicaid. These are the kinds of things that we see as not making this a true negotiation. There are other aspects in the law as well that we think make this very much about giving CMS and the government the leverage to demand a very low price. One of those aspects is there's essentially no floor for most of the drugs. There's a small biotech exception in the early years of the program, but for the most part, there's no floor. There are mandatory discounts that apply to a drug depending on its years of approval, FDA approval. These kinds of aspects of the law, we think, are going to make it very difficult for there to be anything what we would see as a fair price. In addition, manufacturers are subject to very steep civil money penalties if they do not comply with various aspects of the new program. For example, they are at risk of being subject to a $1 million per day CMP for failing to submit information that's determined necessary to administer the program. Also, manufacturers are subject to $100 million for each item of false information, which we think is by far the highest CMP amount in any federal healthcare enforcement regime.
And Sylvia, I think that the excise tax and some of those other very extreme and punitive requirements are exactly what the various litigants are complaining about in the litigation.
And CMS recently issued one of the more notable documents that industry has been waiting for, the revised guidance on the Medicare drug price negotiation program. Was there anything surprising to industry in the revised guidance, Sylvia?
We're still working through the guidance, but there were a couple things that we noticed that had changed. One thing was the gag clause that CMS pulled back on in the revised guidance for IPAY 2026. When we saw this in the initial guidance, we did find this very alarming. This kind of gag clause would have prohibited manufacturers from disclosing discussions or correspondence with CMS related to the MFP price setting process. Frankly, we thought it was pretty insane and unconstitutional, so we're glad to see that it's gone. We also continue to have concerns with some of the new policies that we saw also in the initial guidance. There were a lot of concerns over CMS's decision to create a primary manufacturer, secondary manufacturer construct. This is creating a lot of concern among companies. There's a lot of uncertainty about whether manufacturers can do and accomplish what is needed under the guidance on behalf of the secondary manufacturer. And this is something that I think many people will be looking at more closely.
And I think that's one of those issues where the law does not really fully account for the fact that there will be many sorts of contractual relationships that will need to be retooled, refined, changed in ways that would allow manufacturers to comply with the obligations that are being imposed on them here. If you have a long-term relationship that you have set up for someone else to market your product or someone else to manufacture your product, whichever way the relationship is working, you're going to have contract terms that are based on what the legal environment was at the time that agreement was set up. And so you may not have the ability to get all the kinds of data that CMS is anticipating that you would be in a position to command. So there will be a number of disruptions just in the commercial relationships between companies that will have to be revisited and refined in order for manufacturers to be able to comply with some of these new requirements.
Agree, Connie. This is just one example of how companies are really going to be under the wire if they are in the first class of selected drugs. Not only do they have to report an incredible amount of data relating to their research and development, their patents, their sales and market data. Much of this is proprietary, trade secret, protected information. This 30-day, period basically that runs between the date of the list of published drugs, September 1st, and the October 2nd deadline is putting a lot of pressure on companies to gather this data in a very truncated amount of time. And we raise concerns about how many manufacturers do not collect, organize, or maintain data the way that CMS is asking for it. So this will be an area where I know that manufacturers will be continuing to ask CMS for clarity around these kind of data requirements, because at this point, there are a lot of undefined terms. And I think question, given it's the first year, how this data will be acceptable to CMS, and manufacturers have to certify that to the best of their knowledge that it's accurate and complete, and at the risk of very severe civil money penalties, as we discussed.
And I think that highlights a critical point, which is that manufacturers are not monolithic in their organization or their data collection or even their model. Some are much more comprehensive companies, from the research and clinical trials through the manufacturing to the marketing. Others may do one piece of that really within the company and then have some other contractual or remote functions to cover other elements of distribution or marketing of the products. And assuming that all of them will have the ability to fit within this very specific model, I think it is sort of inconsistent with the variation within the industry. I think the burden on the manufacturers has been underrated in terms of what they are needing to do, even to be able to prepare these types of elements of the manufacturer data in order to present them the way CMS is contemplating.
The ICR, the information collection request on the negotiation data elements, estimates that it would only take a manufacturer approximately 500 hours to complete the data requests under what we call the 1194 E1 factors. We think that's woefully underestimating the time it will take and very inaccurate.
Yeah, not surprisingly. I know certainly the amount of time the IRS thinks it will take me to complete my taxes is also definitely understated.
Were there any other aspects of the revised negotiations program guidance that you thought were notable and wanted to comment on?
One of the concerns we have with the revised guidance is the way that CMS has interpreted the term marketed. Their interpretation makes drugs that we think are not candidates for price setting under MFP to now be considered candidates. And because of the way they've defined marketing, we think it creates more uncertainty for manufacturers. We think this is a new and troubling policy that is not supported by a plain reading of the statute. The statute simply says marketing. For background, what CMS is doing is that for an approved generic or biosimilar to be considered marketed, CMS said it would look at the totality of the circumstances, including AMP, average manufacturer price, and PDE, prescription drug event data, to determine if the manufacturer of the generic or biosimilar is engaging in what CMS is calling bona fide marketing of that drug or product. After CMS determines a drug is no longer a qualifying single source drug because there is bona fide marketing, CMS is going to monitor to ensure that there's continued bona fide marketing. And in doing so, they're going to look at whether there's, quote, meaningful competition, even after that drug is no longer subject to an MFP. CMS says they're going to look at licenses and other agreements between the primary manufacturer and competitors to determine if there are limits on the availability of distribution of the drug. And they're reserving the right to use other available data and information sources on market share and market competition. We think, again, this was unnecessary and not supported by the statute.
And again, this will have implications for the manufacturer's decisions about which products to pursue, looking at how they sequence development of products, because there are already issues with uptake of biosimilars. And it's been kind of a hard nut to crack for the companies who have been bringing those to market. So that may be one of the sort of unintended consequences, is that there will be some concerns about which products to pursue moving forward based on how some of these things play out.
I think that's an important message for your listeners. We think that the IRA itself posed a lot of risk to innovation. So CMS, through this guidance, had a choice. But in a lot of places in this guidance, we think CMS could have taken into account the risk to innovation and the impact to patients a bit more. You mentioned the decisions that companies are going to be making about R&D, and this is an area that we know that companies, as I mentioned, are already thinking about. This type of price setting framework, we think, discourages the kind of research and development that occurs in those early years after a medicine's initial FDA approval. And we think it's not going to be sustainable for companies to continue to invest in post-approval research if the price of the drug is set so low before companies are even able to complete that research that's needed to obtain the subsequent approvals for new indications and new formulations. And these kinds of new drugs are important to patients. These are the approvals for different populations, children, the elderly, other subpopulations who might be able to benefit. And we see this a lot in cancer medicines and how cancer research is conducted. And for example, more than 60% of oncology medicines that were approved a decade ago received additional indications. And most of these approvals were actually received 7 or more years after the initial approval. So this is, I think, something that your listeners hopefully will understand better after having heard more about how this law works and how the guidance really, we think, didn't take a lot of this into account and is creating those unintended consequences.
Well, and when we talk about patient access, we're not thinking only about whether a drug comes to market, but about the patient's preference for how they take it, how difficult it is for the patient to take it on a certain cadence, the once a day versus multiple times a day by injection rather than a tablet. It's serious changes that affect what's likely to be the consistency of the patient taking what could be a very effective drug for them. So I think we need to understand that more broadly than just, will a certain product not be approved, or what are we losing in terms of innovation there? We're losing innovation that actually brings patient benefit. And some of that gets lost in this discussion of just price. The other thing that I think is going to be critically important, and I was excited to see that the PhRMA lawsuit does include a patient advocacy group, because the patients are quite strongly affected by this law as well, or will be. And I think the patients have had a limited voice so far in terms of being able to raise those issues, although certainly we have seen some. But I know that one of the things that CMS has spoken about recently as one way that they are proposing to include some patient voices in the conversation would be through a series of some patient-focused listening sessions around the time as they select the products for negotiation, and to provide some opportunities for the patient voice to be heard there. And I'm hoping that that's done really in a fulsome way, where there is an opportunity for the patients and the manufacturers who are trying to serve those patient populations to be able to explain what some of these things mean in a way that it will be clear to CMS.
Connie, we agree that we'll have to see. I think the operative term here is listening session. CMS seems to want to listen, but if the calls that they did with patients this year so far are any indication, it's exactly what you said. It's hard to have a meaningful dialogue when patients are not necessarily getting the information about how CMS is going to be taking into account these factors, the 1194 E1 and E2 factors. And in particular, these E2 factors are where patients can weigh in with CMS about the therapeutic alternatives to the selected drug. And one of the challenges, we think, is that the process right now is through this awkward, burdensome questionnaire format that patient groups, many of whom have very small staff and are not really familiar with this kind of engagement with CMS. These kinds of forms, if anybody has looked at the ICR, they come with word limits in terms of what you can actually put in the form. And we don't know what these listening sessions will look like. We don't know the format, whether or not there'll be one meeting per selected drug, or will it cover all of the drugs in one meeting. There's no real formal mechanism in place. The statute states that CMS shall implement this section by program instruction or other forms of program guidance. And CMS has interpreted that language to mean that in the critical initial years of implementation, they are not subject to the notice and comment requirements of the Administrative Procedure Act or the Medicare Act. Because of that, CMS has used other forms such as monthly manufacturer calls, which many of us found to be not as helpful as we would like. I think that it is not an adequate substitute for notice and comment rulemaking because it lacks the procedural safeguards of APA rulemaking. There, agencies must define terms with precision, and they need to provide an agency rationale so stakeholders can understand how CMS is reading the law and developing its policies. What makes that bar on front-end input even worse, though, is that the IRA also denies manufacturers and other stakeholders the right to administrative and judicial review on key decisions on MFP implementation, including the selection of drugs, determination of QSSDs, qualifying single source drugs, and the determination of the MFP under the law. We're just not aware of any statute that bars review on both ends of an agency's decision-making process when making decisions that have such a high impact on providers, patients, and manufacturers and other stakeholders.
Oh, I think that's important to remember. I mean, under the Administrative Procedure Act, one of the standards is whether the agency's position is arbitrary and capricious. And if you don't have a significant, robust enough explanation of why the agency is doing what they're doing, it's difficult not to be concerned about that. There is a certain feeling that this initial implementation really should not be etched in stone. The fact that they're not necessarily incorporating a lot of flexibility, or at least not committing to do that, I think is what's creating some of the anxiety for the stakeholders under these programs.
Thank you, Sylvia and Connie, for taking the time to participate in today's discussion on recent updates on implementation of the IRA. And thank you to all of our listeners. I'm your host, Alexis Boaz. If you like what you hear today, please don't forget to subscribe. Diagnosing Health Care is available wherever you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare and life sciences, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. This podcast is presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of legal services to be performed is greater than the quality of legal services performed by other lawyers.